Hello and good evening. My name is Crystal Fletcher, and I am here to present Hemophilia A, Silent Carriers and Bleeding Sons, a pedigree analysis of hemophilia A, an X-linked recessive disorder for Biology 220 Human Genetics, Human Disease Pedigree for Dr. Jocelyn Reeder, June 10, 2025. In my introduction, I will explain what hemophilia A is. Hemophilia A is a monogenetic X-linked recessive bleeding disorder. This means it results from a mutation in a single gene, specifically the F8 gene located on the X chromosome. The mutation leads to a deficiency in clotting factor 8, which is critical for blood clotting. Because of its X-linked nature, males who inherit the mutated gene will almost always be affected, while females are usually carriers. Mothers can be silent carriers and unknowingly pass the mutation to their sons. No male-to-male transmission, since fathers contribute the Y chromosome to their sons. Hemophilia A, an X-linked recessive inheritance pattern, which means the gene responsible, F8, is located on the X chromosome. Males only have one X chromosome, so if they inherit a mutated F8 gene, they will be affected. Females have two X chromosomes, so they are typically carriers unless they inherit two copies of the mutation, which is rare. A carrier mother has a 50% chance of passing the mutation to each son, who may be affected, and a 50% chance to her daughter will be a carrier. There is no male-to-male transmission since fathers give their Y chromosomes to their sons and not their X. In our next slide, we will discuss the pedigree chart tracing the inheritance of hemophilia A through 5 generations of a hypothetical family. The trait is passed down through the maternal line as shown by the presence of carrier females, which are indicated by open, clear circles, and affected males indicated by fully shaded squares. The absence of male-to-male transmission confirms the X-linked recessive pattern. We can see that carrier mothers pass the mutation to 50% of their sons who may become affected and 50% of their daughters who may become carriers. This visual demonstrates how genetic traits can be silently carried and suddenly expressed in future generations. In my next slide, I will discuss interpreting the pedigree, tracking hemophilia A. Now that we've seen the pedigree, let's interpret what it tells us. In each generation, we can trace the inheritance of hemophilia A by identifying carrier females and affected males. The disorder consistently appears in males, especially those born to carrier mothers, confirming the X-linked recessive inheritance. We observe that females may carry the gene without symptoms, but they pass the mutation to their sons, children, specifically their sons. Additionally, since males cannot pass the mutation to their sons, any affected males do not have affected sons in the next generation. This pattern highlights the importance of genetic counseling, especially for women with a family history of bleeding disorders. In our next slide, let's look at signs and symptoms of hemophilia A. Bleeding, joint pain, bruising, fatigue, and brain injury. Some of the determining factors for bleeding are prolonged bleeding after injuries, surgery, or dental work, spontaneous bleeding into joints and muscles without injury, and intracranial bleeding. Points to highlight for joint pain are swelling, especially in the knees, elbows, and ankles. Large, deep bruises that form easily pertain to bruising. Signs of fatigue include chronic blood loss and anemia. Head trauma due to falls are factors in brain injury. Mild cases might go unnoticed until a major bleeding event, while severe cases are often diagnosed in infancy. In rare but severe cases, intracranial bleeding can occur, especially in infants with undiagnosed hemophilia A. Even minor head injuries, like falling during play, can lead to dangerous outcomes and require emergency care. Recognizing these signs early is crucial for initiating treatment and preventing implications. In our next slide, we will discuss causes and genetic inheritance of hemophilia A. Hemophilia A is caused by a mutation in the F8 gene, which is located on the X chromosome, specifically at the location XQ28. This gene is responsible for producing clotting factor 8, a protein essential for blood clotting. When the F8 gene is mutated, it can result in reduced or completely missing factor 8, which leads to prolonged or spontaneous bleeding. Over 1,000 different mutations in this gene have been identified, each impacting clotting function differently. The severity of hemophilia A is categorized based on the amount of active factor 8 present. Severe cases are less than 1% of activity. Moderate are 1 to 5%, mild are 6 to 40%. Because this is an X-linked recessive disorder, males who inherit the mutation are affected, while females are typically carriers. This inheritance pattern explains why hemophilia A primarily affects males and why early genetic counseling is so important in families with a history of bleeding disorders. In this next slide, genetic mutation behind hemophilia shows the DNA double helix, the molecular structure that carries our genetic information. Hemophilia A results from a mutation in the F8 gene located on the X chromosome. DNA is made up of nucleotide bases, adenine A, thymine T, guanine G, and cytosine C. Even a single base change like G to A can result in the body failing to produce enough functional factor 8. These mutations disrupt the transcription and translation process, leading to a defective or missing protein. This genetic breakdown is the root cause of the bleeding symptoms seen in hemophilia A. Diagnosis of hemophilia A often begin with clinical suspicion such as frequent bruising, prolonged bleeding, or spontaneous joint bleeds, especially in young boys. If a family history of bleeding disorders is present, providers may test early in infancy. Laboratory evaluations include a prolonged APTT, which means activated partial thromboplastin time, which suggests a clotting disorder. Prothrombin time, PT, usually remains normal, which helps narrow the diagnosis. The definitive test is the factor 8 activity test, where levels below 1% confirm severe hemophilia A, while higher percentages indicate moderate or mild cases. Genetic testing can identify mutation in the F8 gene, allowing for carrier detection, prenatal diagnosis, and genetic counseling for families. This flowchart summarizes the step-by-step process for diagnosing hemophilia A. It begins with clinical observations such as frequent bruising or prolonged bleeding, especially in young boys. If there is a family history, testing early may start. Blood tests are ordered, specifically APTT and PT. A prolonged APTT with a normal PT is a red flag for a factor deficiency. A factor VIII activity test then confirms how much clotting function remains. Finally, genetic testing identifies mutation in the F8 gene, confirming the diagnosis and treatment for family and planning. In our next slide, let's discuss treatment and management of hemophilia A. The cornerstone of treatment for hemophilia A is factor VIII replacement therapy, which involves intravenous infusion to replace the missing clotting protein. In mild cases, a medication called desmopressin can temporarily increase factor VIII levels. Gene therapy is also emerging as a promising long-term solution, potentially offering a more permanent fix. Managing this disorder also includes lifestyle adjustment and regular care from a multidisciplinary team. The primary treatment for hemophilia A is factor VIII replacement therapy. Where patients receive infusions of the missing clot factor to prevent and treat bleeding episodes. In mild cases, desmopressin DDAVP can be used to stimulate the release of any stored factor VIII already in the body. An exciting development in the field of gene therapy, which is currently being explored in clinical trials. This approach seeks to correct the F8 gene mutation at its source. Beyond medications, lifestyle adjustments play a key role. Patients are often advised to avoid contact sports, use protective equipment, and seek early treatment for any signs of bleeding. Most patients benefit from being treated at specialized hemophilia treatment centers, where care is coordinated by a team of doctors, nurses, physical therapists, and genetic counselors. In conclusion, hemophilia is a serious but manageable X-linked recessive disorder that primarily affects males due to mutation in the F8 gene. Carrier females can silently pass the mutation down through generation, making pedigree analysis and genetic testing essential tools in managing this condition. Early diagnosis and treatment, including factor replacement therapy and gene therapy trials, can significantly improve quality of life. Understanding the inheritance pattern, the underlying mutation, and the available interventions equips individuals and families to make informed medical and reproductive decisions. As research continues to advance, the future for those with hemophilia A is becoming brighter, guided by science, strategy, and supportive care. At this time, I would like to say thank you for listening. Thank you for your time.